Is it visible?
It's visible to me, ma'am. Is it visible?
Yes, yes, I can see, ma'am.
Okay, okay. Uh, Mr. Isaac, a 50-year-old male hailing from Tambaram, came with chief complaints of shortness of breath for the past 10 days, chest pain for the past 3 days. History of presenting illness. The patient was apparently normal 10 days back, after which he developed dyspnea for the past 10 days. Insidious, gradual in onset, progressive in nature. It progressed from grade 2 to grade 4 on MMRC scale of dyspnea. Then there's no diurnal variation, no paroxysmal nocturnal dyspnea or orthopnea, no aggravating or relieving factors.
Um, Regarding that aggravating and relieving factors, uh, you took the history from a patient, no, or it was a clinical scenario?
Clinical scenario, ma'am. I
Okay.
got it from
So,
someone.
okay, okay, I understand. So, when the patient is, as you say, there's progress from grade 2 to grade 4.
Yes, ma'am.
So, you can't say you don't have any specific aggravating or relieving factors.
Okay,
So,
okay.
he'll be dyspneic even at rest. So, when
Oh,
he is present to you, he'll be dyspneic at rest. So,
okay.
even a mild exertion, so day-to-day activities, or his walking. He's walking
Hmm,
when he's walking, even for his toilet, he will become dyslexic. So you have to
hmm,
tell about the aggravating factor. So
hmm.
whenever he is exerting, it is aggravating.
Okay.
Okay. So even
Hmm,
he is rest for some time. So after a period of work, then only it takes time for him to relate. So
hmm,
usually
hmm,
it relieves late for a case of respiratory illness. No.
hmm, hmm,
So, so you have to tell about the aggravating relieving factors. You can't
hmm,
say you don't have any specific aggravating or relieving factors.
hmm. Okay.
You asked about the diurnal variation. Is there any postural variation for this? If
Uh,
in any particular posture is very dyspneic, is it
Postural areas. No, no, ma'am. No,
any
I
specific
guess.
posture that he is not able to? You told me like orthopnea, he's not able to lie flat.
Like light. Yeah.
Yeah, he is lie flat. So what will happen? So everybody knows it's okay. You are going to present a case of pleural effusion. So, how will he present to you? Any specific, any lateral position when he feels more breathless? Any specific position he feels less breathless when he's lying down?
Uh,
Any specific
like.
side I need to say?
Yeah, yeah, yeah. Yes, yes, yes.
Yeah. Is that significant in your case?
Yes, ma'am. Yes, ma'am. He does
Very
have like
significant. Yeah.
left side.
If he lies on the left side, what happens?
Uh, he feels breathless.
Okay. Which side is the effusion you are going to present on?
Uh, Sorry, ma'am.
Which side effusion is going to present on?
Left side, left side.
Okay. So left side effusion, how it will be? When the
Uh,
patient lies on the left side, he will feel better or more breathless.
he will feel uh,
Better.
better. Yeah.
Because yeah, if he is lying on the normal lung, lying on the side of a normal
Yes,
lung
yes,
on
yes,
the
ma'am.
right side,
Mm,
he will become more dyspneic.
mm.
Okay. So
Yes,
this
ma'am.
side is important and you have to talk about the aggravating and relieving factors in this case.
Okay, ma'am.
You just add on.
Mhm.
Can you tell about the MRC grading that you have done for the
MRC grading. Okay. Grade one is uh, like um, only on like, exertion the patient experienced dyspnea.
what type of
Dep-
exertion?
like strenuous exercise.
Okay.
Then grade two will be like climbing a slight slope or hurrying on the on level.
Okay.
Hello, ma'am.
Ah, yeah. Can you continue?
Okay. Then next would be like then the person would be walking slower than like people of the same age. Will have to take breath like after some time.
Okay.
Then then Next stage would be the patient would have to take breath like after walking every 100 meters. Then the
Not
grade 4 would be dyspnea while undressing, changing dress and leaving home.
is that
Hello.
is that anybody else wants to contribute to him? Wants to help him?
Then dyspnea at rest.
Then that
After
comes under.
that comes under
Okay.
Zero, ma'am. Grade 0, ma'am.
It's zero.
Uh, strenuous exercise.
So he told like it has progressed from grade 2 to grade 4.
grade 4. Yes.
So what is grade 4 then?
Grade
Grade
4 is too breathless to uh, change dress and leave home.
Even at rest, he's not able to do anything. His day-to-day activities, nothing. Huh?
Uh,
Even less than his day-to-day activities, he's not able to perform. He is even dyspneic at rest.
mm,
Okay,
yes, ma'am.
continue.
Shall I move to the next page?
Yes, sure.
Okay. Then chest pain for the past 3 days on left side, insidious in onset, progressive in nature, stabbing pain, continuous, not radiating, no postal variation, no aggravating or relieving factors, and not associated with nausea or vomiting, not associated with food intake.
Okay. So you have to rule out from cardiac
Serious,
cause. Yeah,
yeah.
cardiac and the respiratory cause. So how do you say this pain is only respiratory pain,
Mm,
from our system?
uh, so,
How do you differentiate the
uh,
cardiac and a non-cardiac chest pain?
it's not radiating, uh, then
We can go in a direction as you have presented, maybe the
mm,
side, onset, like that we can go. So
okay.
how do you say it's a non-cardiac chest pain?
Uh, mm, it's okay. It's continuous and it's not radiating.
Okay, very good. Cat stick
And
pain is there. It's only a stabbing or a pricking pain.
um,
So cardiac pain will be the
sharp.
compressive squeezing type of pain that is
Uh,
radiating to the jaw or the left
left arm.
shoulders. Okay, you can go up to the diaphragm also. So
Mm,
usually it is not continuous,
mm,
right? And it has specific aggravating relieving
factors.
factors also.
Mm.
Then
Uh, shall I move to the next one, ma'am?
uh, regarding this aggravating chest pain, can this aggravate? Then can the non-cardiac chest pain have aggravating and relieving factors,
Non-cardiac position,
especially with the pleural effusion?
especially pleural
Pleural
effusion.
effusion, patient with pleural effusion, can it aggravate? Usually it
Aggravate.
aggravates with cough.
Okay.
Pain will
Uh,
come
a-
with cough.
aggravates with um,
And what pain will be associated with food intake?
uh,
No, you have just ruled out. No, I'm just asking you.
uh,
You have added it's not associated with nausea, vomiting, or not associated with food intake.
okay.
You're trying to rule out
Uh,
GI causes, any
GI
peptic
cost.
ulcer. Yeah,
Okay, okay,
any peptic ulcer that is being referred as a chest pain. So you want to
okay.
rule out that. Yeah. Then go to the next.
Can I move to the next one?
Yes, yes.
No history of cough with expectoration, hemoptysis, fever, wheezing, night sweats with evening rise of temperature, loss of weight and appetite. Uh, no history of syncope, palpitation, facial puffiness, abdominal distension, pedal edema, oliguria, hypochondrial pain. No history of dysphagia or hoarseness of voice.
So each Each one you have ruled out.
uh,
What do you mean by saying that he didn't have any cough with expectoration?
TB.
Tuberculosis.
uh,
Tuberculosis
uh,
will have cavity.
mm,
See, tuberculosis cavity or consolidation will have cough with expectoration. Okay.
mm,
So TB, as in your case, it can be because of pleural effusion. So it can be TB can present with to you without cough and expectoration also. So especially a
mm,
consolidation or a cavity form of tuberculosis can present you with cough with expectoration.
mm,
Hemoptysis.
mm.
So what do you mean rule out? Patient doesn't have hemoptysis. So
Uh, TB and
cavity again. TB or old history of TB with cavity that is rupturing and causing hemoptysis or what else? What are the
uh,
causes for hemoptysis?
cause of
Few
hemoptysis.
causes. Yeah, few causes of hemoptysis.
Uh, then malignancy.
Yes, bronchogenic carcinoma.
Then
Then,
uh,
TB itself, ma'am.
yeah,
TB.
tuberculosis, the cavity. Cavity can cause hemoptysis. Sometimes
Mm,
massive hemoptysis it can present you with. Then,
then
Ma'am, possibly bronchiectasis.
yes, very good. Bronchiectasis where you have a permanent dilatation, cystic dilatation of the alveoli, and what happens? You have
Bronchi. Uh,
yeah. Then you have
Infection and scarring. So,
and then can repeatedly infect, goes for scarring, and you can present you with hemoptysis. Okay. Then you want to rule out night sweats, evening rise of temperature, loss of weight, loss of appetite. So you want to rule out
tuberculosis.
tuberculosis. So when you present a case like this, with we have not taken the uh, findings from the patient. Try
Yes, ma'am.
to incorporate this night sweats also because you are going to present you as a tuberculosis case, right?
Yes, ma'am. Mm,
So better you incorporate.
mm,
Patient has history of loss of weight, loss of appetite. Typically, this patients will have loss of weight and loss of appetite.
mm, mm,
You just had as a positive history, not in the negative history,
mm,
especially in a clinical scenario where you have not taken a case from the patient. Okay.
Okay.
Then what next? What next you have to what? What do you mean by ruling?
ma'am, pleural effusion can have loss of weight, loss of appetite, ma'am,
Yeah, still we can have
because of underlying TB, ma'am.
tuberculosis. Yes.
Okay.
And this is actually such a case. Like, can
Yeah, I understand.
uh, can
Next,
I move
syncope. Yeah, syncope.
syncope?
Negative history. No.
Uh, Syncope.
What do you What do you mean by what do you want to rule out in this syncope, palpitation, facial puffiness, abdomen distension, all these
Mm, serious causes
serious causes? What
like
or
CCF.
or the
ca-
uh, the right heart failure?
Okay.
Symptoms of right heart. Is there any symptoms of right heart failure? So
Mm,
RS can cause progressive. So it's one of the complication of the respiratory system. Just in case of
Corpulmonary.
failure. Yeah, call for nail, especially you want to rule out here. That is what I was expecting. Yes. This dysphagia and hoarseness of voice, why you want to add here?
hello.
Yes, why you want to have a negative history of dysphagia and hoarseness of voice?
Uh, Dysphagia, hoarseness of voice, uh, uh, tumor compressing esophagus
Hmm.
to rule out.
Okay, so hoarseness of voice also. You want to rule
Uh,
out any tumors.
uh,
When you put something in the when you commit something, you should know why are you putting and you have to justify and why I have told this. Okay, that is what
okay.
you did. Okay, then you can move on.
Can I move to the next page?
Yes.
Past history. No history of similar complaints in the past. Not a known case of diabetes mellitus, hypertension, asthma, TB, epilepsy, or neuromuscular disorders. No history of recurrent respiratory tract infections, exanthematous fever, trauma, tooth extraction. No history of previous surgery or hospitalization.
So this past history, how would this helps you?
Uh,
Similar complaints, there were no similar complaints. So okay, then why do
then
you want to have a history of diabetes, hypertension, asthma? Is it significant here?
mm, to rule out the
Mm.
to rule out if it is a relapse of
Okay, especially when there is diabetes mellitus uncontrolled, a previous pulmonary TB, primary
yes,
complex, at
mm,
an younger age can get
mm,
reactivated. Yes, very good. Then
mm,
there's no previous history of TB or ATT treatment. Epilepsy
mm,
in an RS case. Why
okay
you want
then
to roll out epilepsy in an RS case?
uh, uh, recurrent
Neuromuscular, neuromuscular junction disorders. Why you want to roll out?
mm, recurrent laryngeal nerve.
Oh, especially what you say is like epilepsy when there is loss of consciousness, patient can aspirate.
Okay.
So recurrent respiratory aspirations can be there. You see in a
Mm,
patient with seizure disorder. So history of seizure some maybe 1 week before. Now he is coming. Now he can come to you with fever and cough with expectation. When you examine, you see a consolidation
mm,
because of aspiration.
mm,
So you have to rule out that. What else? Recurrent respiratory tract infection,
uh,
exanthematous fevers,
uh, uh,
trauma, tooth extraction.
mm,
How this exanthematous fever will help you to rule out?
uh, previous infection.
Okay. So he is beginning.
Measles, one
Hmm.
complication is
Yes.
pneumonia.
Pneumonia is very good. So trauma.
Uh,
Hmm.
uh, chest
Trauma
traumas.
to the chest. Yes, yes.
Yeah.
Chest trauma can present you with
Uh, Similar
pneumo
symptoms.
similar presentation with pneumothorax,
Mm,
hydrothorax, or
okay.
what can represent you with?
Mm,
Blood in the
blood in uh,
hmm.
hemoptysis.
Okay.
What do you say that?
Hemothorax, no?
Hmm. Okay. Then
Then,
tooth
then
extraction, same thing like that.
mm,
Epilepsy. You can also aspirate. Okay, ma. No previous surgery or hospitalization.
uh,
How that is significant?
to,
If
to
he is
rule out
he has a history of hospitalization 1 week before. Now he has cough with expectation fever. What is that called?
infection, can be infection
Yeah, infection
due to
acquired from the
surgery.
acquired from the hospital.
Yes, ma'am.
Hospital acquired infection. You have to
Rule out.
rule out. So
Mm,
two categories will be there. Pneumonia, community acquired pneumonia or the hospital acquired pneumonia.
yes,
If
ma'am.
it's going to be an hospital acquired pneumonia, you have to straight away start on a higher antibiotic, and there can be a suspect for infection with a resistant type of bacteria or
Mm,
virus.
mm,
With bacteria especially, resistant bacteria can be the cause. You
mm,
have to start away on a higher antibiotic. So in that case, this previous history of surgery or hospitalization will help.
yes, ma'am.
Okay. Okay. Move for the next slide.
Family history.
Hmm.
History of pulmonary tuberculosis. Diagnosed to his wife 5 years back, and anti-tubercular treatment was started. Discontinued treatment within 1 month. Resides in Kacha House.
Okay. So Only this will you see in tell in your family history?
Yes, ma'am. Only this
Okay.
was given.
Okay. This was given. Okay.
History of asthma or anything?
Ah, history of any family history of that genetic inherited disorders.
Mm,
You have to ask whether similar findings are there in the family members or siblings. Sibling,
mm,
especially sibling history, you will be asking whether it was an inherited or not.
okay.
History of asthma, you have to ask in case of respiratory disease. Okay?
Then shall I move to the next slide?
Yeah, yeah.
Personal history. Mixed diet consumer. An alcoholic for 30 years. Consumes about 200 milliliters per day. History
Mm,
of chewing tobacco on and off for the past 10 years. No history
okay,
of smoking. No history of occupational exposure.
okay. So, personal history. We have a risk factor, alcoholic. He's an alcoholic who has
Yes,
poor nutrition.
yes, ma'am.
So he will not be able to take good diet. So
Yes, ma'am.
he can be a risk factor for acquiring tuberculosis. And
Yes,
he
ma'am.
is chewing tobacco.
Yes,
That. So this alcoholic can also have present you with aspiration pneumonitis. No.
yes, 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 ma'am.
Okay. So smoking.
Um,
No history of you have said no history of smoking. How the smoking will be significant here? When you have a smoker, suppose especially smoking.
uh, smoking.
Mm. Suppose he is a smoker.
COPD,
COPD lung can be there. Bronchogenic carcinoma has
carcinoma.
been suspect.
Yes, ma'am. Yes, ma'am.
Even this effusion can be a malignant pleural effusion
Yes,
secondary to
yes,
the
yes, yes.
bronchogenic carcinoma. So occupational exposure. So how you didn't tell me how what is he working? He has a diet and work is also important here, no? What type
Yes,
of
ma'am.
work is there? So you want to rule out occupational exposure. So can you name few occupational diseases,
Uh,
especially for lungs?
Asbestosis.
Asbestos. Okay. Then
Then uh,
it comes under pneumoconiosis. Got from no?
mm,
Silicosis,
Silicosis can be there.
uh,
Then
anthracosis, bagasosis.
okay. So a lot of occupational exposure disease are there. So you want to
yeah.
rule out. There's no occupational exposure. That's very good. Then next slide.
Treatment history. No significant treatment taken.
He has not been hospitalized.
Yes,
So
ma'am.
when you take a clinical scenario like this, don't commit as alcoholic for 30 years. Drinking 200 ml per day, you will not be there. Okay,
Okay,
so
ma'am.
make it around 10 years.
Okay.
10 years.
Mm.
Okay.
Then case summary. A 50-year-old male, Mr. Isaac, came with chief complaints of dyspnea of grade 4, trypopnea on left side, chest pain, not associated with fever, cough with expectoration or hemoptysis, no history of cardiovascular or malignant symptoms. Thus, the system involved is respiratory system.
Okay. So what you have from the family history significant that also you
Uh,
have to bring out in the summary.
yes, ma'am.
Okay,
TB,
whatever
wife,
significant, yeah, history of TB in the family. His wife was suffering from tuberculosis, not under treatment also.
treatment.
He's a
Yes, ma'am.
treatment defaulter. With the defaulter, the family,
Yes,
but
ma'am. Uh, uh, he doesn't have
doesn't
symptoms
have
of TB.
cardiovascular. Okay, TB.
Okay,
Didn't have any cardiovascular or malignant.
malignant symptoms.
What do you mean by say like you want to say no loss of weight, loss of appetite?
Uh, no, he has no loss of weight or appetite.
I would
Hello.
suggest to have, yeah, I would suggest to tell like You can leave this, no? The no associated fever, cough, expectoration. What do you mean to say? That it has not been under, there's not progress to complications.
Yes, ma'am.
That's what you want to say.
Okay.
It's a
Yes, ma'am.
plain tuberculosis TB. It has not gone for any complications.
Yes, ma'am.
I think you can avoid these malignant symptoms.
Yes, ma'am.
Okay. You want to proceed to examine the respiratory system.
Mm.
You want to localize this to the respiratory system alone.
Yes, ma'am.
So this, how do you differentiate from this respiratory system and the RS system? Main difference.
Uh, Sorry, ma'am.
Symptoms. So most common symptoms is breathlessness and chest pain, which is very common, very most common symptom in the CVS
CVS.
also. Yeah.
Mm.
So you why you want to say it's only RS because RS like he didn't have any cough expectoration also. Yeah. So why
Yes,
do you
ma'am.
want to say why you want to justify it's only the RS system that is involved
Uh, the
and not the CVS? What makes you think from the history because you have not examined the patient till now from the history.
mm,
So what makes you think you are very sure it is only the RS I'm going to examine? What makes you think like
family history of TB is
that?
very.
This TB can involve the pericardium also.
Uh,
Chest pain because it can be because of pericarditis. Breathlessness can be because of the pericardial effusion. And
uh,
also you don't have any cough expectoration. Yeah.
yes, ma'am.
What made you think it's only an RS system, pure RS system, and CVS is not involved from the history?
Mm, mm,
Somebody could help him.
Ma'am,
Hmm.
lack of palpitations,
Hmm.
syncope, and
Hmm.
lack of symptoms of heart failure,
Hmm.
and the fact that it's a presented dyspnea and that the chest pain is exertion, not exertional,
It is not exertional. It is
not
very localized to left only.
localized,
Okay.
Lateralized.
Hmm.
lateralized.
He doesn't have PND and orthopnea.
Yeah.
Yes, ma'am.
Some symptoms. So other symptoms have not been symptoms, especially with CVS. Attended CVS doesn't have. So this is how I justify it's only a RS case, and I would like to proceed with the RS system. That is how you will be presented.
Yes, ma'am.
Carry on.
General examination.
Hmm.
Patient is conscious, comfortable, oriented to time, place, and person, moderately built and nourished.
Okay.
Clubbing is
Again,
present.
when you want to present a TB case with 30 years of alcoholism, he can't be moderately built and nourished.
Okay, ma'am.
Change it to maybe he's been built and
Mm,
malnourished.
mm,
That will be apt for the
okay.
presentation.
Mm. Then clubbing is present, bilateral, grade 2. Then no pallor, no icterus, no cyanosis, no pedal edema.
Hmm.
Then no generalized lymphadenopathy, no TB markers such as flectins, erythema nodosum. No HIV markers such as oral candidiasis, HSV
What these
infection.
comes under ma? TB markers like flectin and erythema. What are they?
Uh,
They are hypersensitivity markers, huh?
yes, ma'am.
Yes. Okay. Okay.
Then, no HIV markers such as oral candidiasis, HSV infection, molluscan uh, contagiosum.
Okay. Why you want to rule out HIV here?
Uh, HIV because
It's an
it can
immunosuppressive.
pneumonia,
Yeah.
pneumonia.
Hmm. So again,
HIV
patient
and
with
TB are associated. No?
no,
HIV and TB are associated, so that's
associated is very good because they are, because it's a CD4 count falls and immunity
most common
fades,
opportunistic infection.
infection becomes flare. But what will the difference here when you have a adult with HIV and tuberculosis? How it presents? Normally, adult TB will be normally adult TB will be a fibrocavitary disease or a pleural effusion. And in HIV, it presents as a presence with lymphadenopathy, consolidation, or with in the form of miliary tuberculosis.
Mm.
When the host response is very poor, it doesn't localize to the apex of the lung and form a cavity or fibrosis. Present you with a progressive disease, progressive pulmonary tuberculosis, the miliary tuberculosis. So that is how it presents. HIV with tuberculosis presentation is a little bit varied.
Yes, ma'am.
Okay. So what are the other causes for generalized lymphadenopathy? Or few
Uh,
causes for tell me few causes of generalized lymphadenopathy.
mm,
Okay, then tell me what is generalized lymphadenopathy. When you say it is generalized lymphadenopathy, what are the
uh,
areas you will be looking for?
neck and the neck lymph nodes of the neck could be enlarged. Neck,
Mm. Mm.
then axillary lymph nodes.
Mm. Cervical, you say, no? Cervical lymphadenopathy.
Yes, ma'am.
Okay, axillary. Else you will look for lymph
Mm,
nodes, palpable lymph nodes.
then cervical. Then
Inguinal.
inguinal. Yes, ma'am.
Mm. Okay. So there's no generalized lymphadenopathy. You will look for all these areas and few causes, as somebody told, lymphomas. Then,
Then
Tuberculosis
uh,
itself.
yeah, tuberculosis. Then,
Syphilis one.
generalized stuff.
No.
Okay. Then,
then
will not HIV itself present with generalized lymphadenopathy?
yes, ma'am.
HIV. Yeah.
Yes.
Yes, malignancy.
Hmm. That not be generalized. Only malignancy will have the draining lymph node that is involved.
Yes, ma'am.
Okay. Okay, ma
Mm,
proceed. Ma proceed.
then shall I move to the next slide?
Yes, yes, sure.
Then vitals.
Mm.
Respiratory rate is 25 breaths per minute. Abdominothoracic. Then
Okay.
pulse rate is 90 beats per minute. Regular. Normal volume and character. No radio radial or radio ephemeral delay. Felt
Mm.
equally on all peripheral pulses.
Okay.
BP is 110/70. Measured in sitting position in left arm. Temperature is febrile. Then jugular venous pulse is not raised.
Okay. Normal respiratory rate.
Normal respiratory 16 to uh, 20, 20, ma'am.
20. Okay. So now what do you mean by say? What do you mean to say now? Is 25.
Like the patient is hyperventilating.
Mm. But
Mhm.
apnea is there. The breathing is abdominothoracic. Pulse okay. So what have you rolled out on all these pulses? Is this in any specific uh, pulse you have to rule out in RS system?
Mm,
Regular, normal volume, character, radiofemoral, radial, held in all peripheral pulses. Anything you want to say add on here? Specific, I
see,
want to see all this in RS system because I want to rule out something.
mm,
All peripheral
pulse,
pulses, maybe.
uh,
How it is significant in your RS system?
mm,
Anybody else to help them?
And pulses,
pulses,
paradoxes.
paradoxes.
Hmm. When it will happen?
Constrictive pericarditis, no?
When it has been gone for a complication.
Okay.
Okay, pulmonary TB that has gone for a pericardial effusion or constrictive pericarditis can present you with. Then
And this there could be large volume pulse in case of carbon dioxide retention.
high volume pulse can be there, especially with COPD for
CO
pulmonary. Not going for pulmonary, the COPD as a combination of carbon dioxide retention, they can have high volume pounding pulse. Then,
Then, because of cor pulmonale, there could be atrial enlargement and fibrillation, irregular pulse.
yes, very good. Then,
Then
why are you worried about palpating all the peripheral pulses to rule out? Do you want to rule out something?
pulses
In an
for
RS
endoscopy.
case. In an RS case.
Um,
DVT. Can have? Can you present with?
mm,
Pulselessness. You can present to pulmonary embolism.
yes, ma'am. Oh,
Pulmonary embolism can also present with you, present to you with the same features. You'll be
yes, ma'am.
breathlessness, chest pain with non-preto cough.
Yes, ma'am.
You
Yes,
can
ma'am.
go for an embolism and pulmonary infarction also. Okay.
Okay.
Then
Peripheral pulses are not felt in pulmonary embolism. No?
sometimes when there is no pulmonary embolism, a DVT, thrombosis, venous thrombosis, arterial thrombosis, that can present.
Okay. Okay.
Next one.
Mm, RS examination.
Yes, very
Upper
good. So
airway.
RS starts from their upper airway. Okay.
Yes, ma'am. Upper airway, nasal septum not deviated. No polyp. Then oral cavity. Loss of teeth with nicotine staining. No oral thrush or halitosis. No tonsillar enlargement. No postnasal drip.
Okay.
Then chest wall inspection appears to be symmetrical, elliptical in shape. Movement with respiration left side much less than right side. Uh,
Okay.
Trachea appears to be deviated to right side. Trail sign is positive. Apical impulse not visible. No drooping of shoulders.
Okay. What else will you say in inspection?
Uh,
Oh, you
Ma'am,
have more to say. Okay.
no supraclavicular or infraclavicular fullness or hollowing.
Mm.
No intercostal retraction. No crowding of ribs or prominence of medial border scapula. No dilated veins, scars, or sinuses.
Okay. This supraclavicular, infraclavicular filling, fullness. You don't have.
Uh, no, ma'am.
No. Okay. What else can be added, ma, here? In case of when you say the patient is tachypnea with respirator 25, in the inspection, what
Accessory
else you want?
muscle use.
Not?
Use of accessory muscles. No?
It's very good. That should be told here. So,
Yes, ma'am.
accessory muscles has been put into action or not.
Mm, mm.
Oh. Are you missing out something in inspection? That's it. I think you can add like fullness is there.
Um, I don't. Okay, the case was given
Uh,
as such.
okay. Okay, ma'am.
It should be hollowing, ma'am.
Oh, fullness will be there. So he's present in case of effusion. Na?
Effusion, okay. So.
Okay, ma'am. Proceed, ma'am. Palpitation. Palpation.
Trachea is deviated to right side. Apical impulse not felt. Uh, chest chest movement with respiration
So what?
is at
How will you start? My inspiratory findings were confirmed with palpation. So especially when tracheas, I find I have confirmed my inspection that
uh,
trachea has been deviated to the right side.
right side.
And
Yes,
as you say, I can't see the apical impulse. So when you feel also by palpation also you can't feel,
ma'am.
or it is being pushed somewhere
Mm,
else you can feel apical
mm,
impulse,
mm,
or you can't feel.
mm.
Mhm. Okay. Then
And chest movement with respiration is
mm,
asymmetrical, with movement
okay,
of left side much less than right side.
okay,
Then chest expansion is 2 centimeter.
okay. So
Then vocal
two
fremitus right.
2 centimeters. How will you say? How will you you will say the expansion altogether? Okay, and you have to say about the Hemithorax expansion also. Right and left hemithorax.
Hmm.
So you have especially you say the movement chest movements are decreased in the left side. So
Hmm.
we are wearing of the left hemithorax more. So is it expanding or movement? You have to see and compare. Like
Hmm.
it's
Yes,
been
ma'am.
expanding around 1 centimeter and is expanding only zero point 0.5 or no.
Hmm. Hmm.
You have to commit upon the hemithoracic
Okay, ma'am.
expansion also.
Hmm.
Okay. Next.
Then vocal fremitus, right side normal, left side it's reduced. No tactile fremitus, no intercostal tenderness.
Okay. Where you get intercostal tenderness?
Uh, Intercostal tenderness.
Empyema, ma'am.
Empyema thoracics. When the pleural cavity is filled with pus. So this
Yes, ma'am.
effusion, or especially pneumonic effusion or secondary bacterial infection, or the thoracic the cavity, TB cavity opening out, getting infected can present you with empyema thoracis. At
Yes,
the
ma'am.
time you'll get the intercostal tenderness.
Yes, ma'am.
Next.
Sure. Okay. Vocal fremitus. It's normal on right side. On left side, it's decreased except for supraclavicular.
Hmm.
Then on percussion, like uh, right side it's resonant. On left side, it's tonical except for supraclavicular.
Clavicle. Clavicle you will get stony dull.
Oh, so yeah.
Just commit dullness. Compared to
Okay.
the right side, clavicle is resonant and left it
Dull.
is dull.
Mm.
Don't commit a stony dull.
Okay.
Supraclavicular, you want to say it has been resonant.
Yes, ma'am.
Okay. Right from intraclavicular,
Tonical.
it's been stony dull.
Mm.
So from this, what can you say? It's a
Uh, uh, Pleural
moderate.
effusion.
Okay, no. Full effusion is with how much is the quantity?
Uh,
It's mild, moderate, massive. What do you want to
mm,
commit as?
massive effusion, ma'am.
Massive pleural effusion. Okay. So it's a massive left-sided pleural effusion. So it is. You can't see that. You can't palpate. You can't see and palpate the apical impulse. So it
Yes,
is.
ma'am.
Is there any mediastinal shift? You want to say
What, ma'am?
mediastinal shift is there?
Yes, ma'am. Yes.
Okay.
Uh, then drop
Tracheal
spaces
shift
of
is so tracheal shift is there along and with the mediastinal shift is there.
yes, ma'am. Then drop space is obliterated.
Hmm.
No shifting dullness. It's straight line dullness.
Where you get shifting dullness?
In uh, uh, oh, stomach.
Huh? Stomach.
Aside,
Yes, tell me, ma.
ascites, ma'am.
It is
Ascites, yeah. Ascitic fluid will be easily can be shifted from this to that. Pleural effusion, mostly you don't
straight
get.
line.
Mm. Straight line dullness you can get. Then, okay, ma. So you have percus then comes next slide, next slide.
Can I move to the next slide, ma'am?
Yeah, next slide.
Auscultation.
Mm.
Breath sounds. Right side normal vesicular breath sound. Left side bronchial sound in supraclavicular. Decreased breath sounds in infraclavicular, mammary, inframammary, axillary, infraaxillary, infrascapular regions.
Okay.
Vocal resonance is normal on right side, and it's decreased in all except supraclavicular on left side. No added sounds.
Mm. So what do you say here? Why is bronchial? Why you hear a bronchial breathing in supraclavicular? Normally, what you get, not you hear
Mm.
Normally vesicular, ma'am.
supraclavicular can be still. Can be still bronchial also.
Okay.
Why?
Mm.
Why? Why?
Because well ventilated, no?
It's close to your trachea.
Oh, close. Okay.
Can have,
Yeah,
especially
okay.
in this case. Why you want to commit as bronchial?
Mm.
Any significant thing you want to stress
In
here?
cavitary lesions, so
Okay, can be there. Yes. Okay. Cavity can be there cause of bronchial sound. What else will cause a bronchial sound?
consolidation, no?
Hmm. Especially when there is the lung which is above the pleural effusion. You can go for consolidation and it can give you bronchial feeling as well. Okay?
Um, mm,
And proceed, proceed. Next slide.
mm. Other systems examination.
Hmm.
CVS S1 plus S2 heard in all four areas. No
Hmm.
murmur. Then abdomen soft, no
So
warmth.
areas where did you hear apical impulse?
What, ma'am?
Now you have where did you hear the apical impulse
Uh,
or S1 S2? Did you auscultate? Where did you auscultate? You told me it was not felt, it was not seen, and it's a massive.
Mitral area.
Where is the mitral area?
Oh. Uh,
Where do you expect to be? Same
it
mid-clavicular.
should be deviated more to the right.
Yeah, you have to commit, ma. Yeah,
mm, mm,
here you
mm.
have to commit about the
Yes,
mitral
ma'am.
area,
Mm,
especially when you are presenting a case of massive proliferation, and obviously the diffusion is massive. There will be a mediastinal shift also.
mm.
So your mitral area will be
Diminished heart sounds, no?
not necessarily when there is a student pericardial effusion, we can commit like the heart sounds are diminished. Now you can commit as being shifted. So where did
Shift.
you auscultate? Where is the mitral area?
No, normally it
Normally,
should be
normally, yeah.
fifth left intercostal space,
Uh,
1 centimeter medial to mid clavicular line.
now where it is
Now it should be maybe just left
Shifted.
of the sternum,
should be more to the right.
more to the right.
Mm,
So you have to commit like that.
okay.
So normally, normal apical impulse being shifted.
Yes, ma'am.
All four areas you can have the S1, S2 with no murmur. Okay.
Mm,
Then,
mm. Abdomen soft, no
mm,
warmth, non tender, no organomegaly.
mm. Especially in your case, you want to rule out concomitant TB abdomen.
Mm.
So how will the TB abdomen will be? How
Uh,
can it be present to you?
mm,
Can be distended with ascites, Dowby feel.
yes, ma'am.
So you're
Abdominal
worried about,
pain.
yeah. So you're worried about the abdomen
Mm,
also.
mm,
Okay. And CNS,
mm.
no focal neurological deficit. What complication can it have in your CNS?
CNS. Mm. TB meningitis.
Meningitis. The patient will present to you with altered sensorium, fever, neck stiffness.
Yes, ma'am.
And with focal neurological deficit, can he present with a
Mm,
localized neurological deficit?
mm,
Yes. Someone? Patient can present to you with tuberculoma as
mm.
a space occupying lesion when similar to a space occupying lesion can the patient can present you with focal neurological deficit.
Yes, ma'am.
So we are worried about the CNS system also.
Mm,
Okay.
mm.
So you have finished examining all. What is your
Okay.
conclusion?
Diagnosis.
Mm.
50-year-old male with chief complaints of dyspnea, trypopnea, and chest pain. Not associated with fever, cough with expectoration, hemoptysis. No symptoms suggestive of severe abnormalities or malignancy. Contact history of TB from his wife. On examination, found to have clubbing, decreased chest wall movement on left side, stony dull knot on percussion on left side, Decreased vocal fremitus, vocal resonance, and breath sounds on left sides with normal right side findings. So it's diagnosed to have left-sided pleural effusion, most probably due to tubercular etiology with no signs of congestive cardiac failure.
Why do you want to say congestive cardiac failure? Not complicated, huh? Without any complications.
Yes,
Without
ma'am.
signs of right heart failure. Okay.
Yes, ma'am.
Then how will you proceed? So you have
Then,
diagnosed. Then
investigations.
yeah.
Complete blood count. Then
How this will be significant to you? Why you want to say it? Because now you have come to an end of lot of investigations. Investigate. You have to justify whether each and every investigations you do is needed or not.
yes, ma'am.
Mm. You have to justify and why.
Mm-hmm.
Say why I want to see this. Why I want to do all these investigations in this patient. Yes.
CBC
Mm.
for lymphocytosis.
Mm.
Then uh, then
He's an alcoholic with malnourished. You like to see his HP, hemoglobin.
yes, ma'am.
Yes. He's alcoholic and how will be his MCV? How can his MCV be? Can present you
Uh,
with the epileptic anemia.
yes, ma'am.
All the hemoglobin indices also you like to see.
Yes, ma'am.
Okay.
Then then renal function test, liver function test. Uh,
Why it is necessary?
mm, Nephrotic syndrome.
Hmm.
Then
Nephrotic syndrome.
yes, ma'am.
See, why are you worried about a liver function test in this patient?
Um,
Ma'am, the patient's alcoholic, so
Yeah. So you
cirrhosis.
wanted to. You can have liver failure before also. So you want to see the bilirubin levels.
Yes, ma'am.
Okay. And where? Okay. So he is not a known alcoholic also. You are worried about LFT for this patient. Why?
Yes, ma'am.
Hmm.
Then
Why?
chest X-ray.
No, liver function test. So
Mm,
this patient is a case of TB tuberculous effusion. So you will be starting him on anti-tuberculous drug. And most of the anti-tuberculous drug will have
hepatotoxicity.
yeah. So you have to
yes, ma'am.
rule out a normal baseline, normal liver function test so that you will be starting ATT, normal regimen of ATT for him. So when his liver is already deranged, you have to put him on a modified regimen of ATT. So you're worried about this liver function test even before starting ATT with a without any history of alcoholism also. Okay.
Mm.
Why you want to do an RFT?
What, ma'am?
Why you want to do an RFT?
Ma'am,
Uh,
rifampin could lead to kidney toxicity. So
Hmm. Kidney toxicity. Yeah. Rifampin. It's
rifam
excreted. It is metabolized and excreted and causes discoloration of urine.
okay.
So baseline RFT you want to no. Okay. Then
then nephrotic syndrome to rule out.
okay, proteinuria is there.
Yes, ma'am.
Patient with CKD.
Mm,
CKD is again susceptible to have
Drug
e-
toxicity.
even more drug toxicity. He has. Then chest X-ray.
yes, ma'am.
What you will see?
Uh, uh, left side will
Hmm.
be yeah,
Left side.
opaque, more opaque than right side. Hello.
What more opaque? What else? What and all you can see in an X-ray of this patient?
Mm,
You told like it is from supraclavicular. It is the bronchial breathing, then the
Yes, ma'am.
entire hemithorax is stony lung percussion. So how do you find
Mm,
will be the X-ray? So what are your
obliteration
findings? You
angle.
can you can confirm. You can see the tracheal position here. You can confirm the tracheal position here. If
Yes,
you
ma'am.
want to, as somebody told me, cavity can be there, can be seen here. Hmm? It's going to be a
Yes, ma'am.
cavity that is causing a bronchial breathing. Then the typical
Then,
mediastinal shift will be there. You can
yes,
see
ma'am.
that in a chest X-ray. Then the diaphragm will be pushed down. What else?
Mm,
If there is any
Fluid level.
calcified fluid level,
costophrenic angle will
will
be
be
obliterated.
obliterated.
Mm,
Cardiophrenic, costophrenic will be obliterated. What else? Any calcified?
then,
Previously, a primary complex node that has been calcified.
yes,
You
ma'am.
see them in the X-ray. Or a hilar lymphadenopathy can also be made out on a X-ray. Okay. Okay. Then
Yes, ma'am. Then ultrasound.
ultrasound.
Yes, ma'am.
Where?
Mm, chest and abdomen. No, no, chest. Like,
Where you can see such a large effusion on a X-ray itself. You want to
yes,
do an
ma'am.
ultrasound.
Uh,
When there is effusion is very mild, when you're
okay,
not
ma'am.
able to take a sample for
Mm,
diagnosis, then you can
mm,
do an ultrasound guided thoracosynthesis or
yes,
paracentesis.
ma'am. Mm, mm,
Not for this case. I don't think
mm,
ultrasound. I
mm,
think
okay,
for
ma'am.
the ultrasound is needed. You
Mm,
are worried
okay.
about the liver, maybe you can do an LFT.
Yes,
I
ma'am.
don't think ultrasound.
Mm,
Maybe
mm,
you can justify. So if you want to do, you can justify. I want to rule out a hepatosplenomegaly, maybe
mm,
or
mm, mm,
abdominal
mm,
lymph nodes. It's going to
mm,
be.
okay, ma'am.
It's not a disseminated TB. I want to rule out disseminated TB. In such a way you can justify your
A
need
pleural
for ultrasound.
thickening can be found with
Fluoro
ultrasound.
thickening, X-ray you can see ma. X-ray it's
Okay.
better. Thickening.
Mm,
Ultrasound, especially maybe invasive, if you want to have a mild pleural effusion and you want to take a sample for diagnosis, then you can go.
okay.
I say like if it's going to be disseminated, if you want to prove that, you can
Yes, ma'am.
check.
Then
Then,
ECG and echocardiogram
hmm, why?
to rule out serious causes.
Serious?
To rule out the serious causes,
Hmm.
right heart failure,
Heart failure. Okay. You want to take an ECG and echocardiogram. Maybe this
echocardiogram.
pleural effusion can be associated with a minimal or mild pericardial effusion. So
Yes, ma'am.
mild pericardial effusion can go unnoticed also.
Mm,
So you are
mm,
worried. You want to
mm,
take an
mm,
echocardiogram. Maybe.
mm.
Okay.
Yes, ma'am.
Mm.
Then sputum culture and sensitivity
But you
to
told
rule
inflammation
out.
is not protective.
Yes, ma'am.
So it's like you investigate pertaining to this patient.
Yes,
There will
ma'am.
be a lot of investigations, lot of background of investigations that
Mm,
will be there.
mm,
But for this patient, what you want, you please testify. Okay,
mm,
this
mm.
if it's
Okay,
not
ma'am.
protecting, if it's not producing sputum, what you will do?
Yes, ma'am.
Then what you will do?
And
Lavage can be done. Bronchoalveolar lavage can be tried.
yes, ma'am.
That in that you can in that specimen you can take in for acid fast
Yes,
screening,
ma'am. Mm.
area levels, or you can check. Okay. Then
This is only when we suspect TB, ma'am, bronchoalveolar lavage.
if
Any
there's a
patient,
tuberculosis, malignancy,
any
that time
patient
also.
who does not, any patient with dry cough with suspicion of TB or malignancy, ma'am.
No, when you have when you when you don't come to a diagnosis conclusion, you want an added specimen for your diagnosis, then you can have
Okay.
lavage. Okay.
Then diagnostic pleural fluid tapping.
Mm.
Then CBNAT.
What will you do after you take the pleural fluid? What all investigations will you do on it?
Um,
What are the list of investigations that you will do?
Protein,
Mm, you can put it as, and divide them as,
exudate and translate.
no, like what are the investigations? Where all you will send the samples for? What are the lab?
Uh,
Which lab you will send the samples for? Microbiology, biochemistry, like that I'm asking.
Biochemistry,
So
biochemistry,
pathology,
ma'am.
yeah. So what are the investigations? First you get biochemistry, no? First
Yes,
step
ma'am.
will give for biochemistry. What are the investigations for biochemistry lab you will send for?
Protein,
Hmm.
then,
Sugar, protein, LDH.
yes, ma'am.
Sugar. Sugar, you
Mm,
worried about the sugar also, no? So
mm,
sugar?
mm. Protein, LDH,
Hmm.
uh,
ADA. You want
yes,
to
ma'am.
know about the ADA also
Cytology,
here.
mm,
Then microbiology samples. What all you send for microbiology?
um,
Grams changing, acid
Hmm.
fast.
TB to
Yeah, acid fast.
acid
Acid
fast
fast,
staining.
gram staining, and also you give us a sample for culture sensitivity also.
Yes, ma'am.
Okay. Then what is the yield of AFD from pleural fluid? How many percentage?
Less, ma'am.
It's very less. Yeah, only 5 to 8% of the persons will have the will can the AFP can be stained in the pleural fluid. Mostly it's sputum.
Yes,
Only if
ma'am.
it's bringing out sputum, you'll be able to confirm.
Mm.
Okay. Then
Then,
microbiology have sent. What else you have to send?
mm,
It's lab that is pending. Path.
yes, ma'am.
What you will ask the pathologist to do?
Malignancy, to check for malignancy.
Cells. You want to see the cells.
Cells, yes.
Nature of the cells. Okay.
Mm,
It's going to be more of lymphocytes. Again, you will have a more evidence for tuberculosis. It's
yes,
going
ma'am.
to be in a dysmorphic or a hyperplastic malignant looking cells. Now you have to
Mm,
rule out malignancy. Okay.
mm,
Then
yes, ma'am. Then,
malignancy, you can also ask them to do a cell block where
yes,
around
ma'am.
50 ml of pleural fluid they will
Mm,
centrifuge and they make a cell block so that the yield will be more. The number of
mm,
cells you can see
yes, ma'am.
under the microscope will be more. You
Mm,
can ask the cell block also.
mm,
What else?
mm,
Previously, we used to do in such a case like you have a massive pleural effusion. So instead of going for a diagnostic tapping, you can attempt a. You needed to have a therapeutic tapping also.
yes, ma'am.
No, you have to
Mm,
let out fluid. So
mm,
only then his dyspnea will become settled. Even
ma'am.
before taking in, even inserting in ICD, you have to tap amount of fluid.
Yes, ma'am.
So what you will see if you leave the fluid for some time
Mm,
in case of
mm,
tuberculosis effusion?
Ma'am, some cobwebbing.
Yeah, very good. Cobweb can be seen. So if you leave the specimen undisturbed in a test tube for say like 24 hours, when you leave it and you come and see in the next day, you can see
mm,
a cobweb appearance
mm.
also. Okay. Then
And
mm,
the next is CB-NAT
mm,
to test for TB, tuberculosis.
mm. What type of test is that?
Uh, what type means?
Okay. What is the
Nuclear,
inference? Uh,
nuclear.
Nucleic acid,
please tell me.
nucleic acid amplification.
Okay. Gene
Mm,
expert. Mm. Gene expert. What 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 is your inference from that?
mm,
Whether it is a resistant.
Resistance.
yes,
There
ma'am.
is there any drug resistance or not?
Yeah,
Is there any
rifampicin.
resistance to the rifampicin and pyrazinamide?
Yes, ma'am.
So if it's going to be a primary resistant tuberculosis, then you
Yes,
have
ma'am.
to straight away start on a second line.
Yes, ma'am.
So any sample you have to send for gene expert also. So whether the uh, organism will be susceptible to first line of ATT or not. So you
Yes,
have to
ma'am.
send a sample for CBNet.
Yes, ma'am.
Then
And CT, chest, and MRI.
why?
Again, rule out.
See, if you're not able to find diagnose anything in X-ray, then you can go for a CT.
Yes, ma'am.
And why MRI?
Uh, mm,
Why MRI? Please avoid, no?
Any
So what? Ah,
soft tissue tumors.
soft tissue tumor is a suspect in case of this much pleural effusion.
Um,
So when there is any tumor, when you suspect, no, you can go, but not the you don't need to say all these in a normal case.
Mark.
Even X-ray, this will when you're not finding anything specific, you can go for CT. CT chest mainly when there is a cavity, when the patient is presenting with all the complications of like when the patients have hemoptysis or the patient has spoots out, coughs out, lot of sputum when you suspect a bronchiectasis. These are
Mm,
complications. When you go for
mm,
some complications, you can go for a CT.
mm,
Sometimes the cavity can give a what is air fluid level. Can go for an abscess formation inside the cavity, empyema or aspergilloma. This cavity, this TB cavity, can be invaded by the fungus, giving an aspergillomas.
mm.
That time you can have a CT whenever you go for a complication. Otherwise, not. So somebody can help him. He has left some basic investigations, some basic what to be ruled out in a TB patient. So
blood
you
sugar.
asked blood investigation. What about?
Blood sugar.
Yeah, you have to rule out whether he's a diabetic or not. As you said,
Yes, ma'am.
you ruled out the history. No, he's not a diabetic. So
Yes,
diabetic patient with uncontrolled sugars will have TB. So you have to rule out, take a fasting postprandial sugars and HbA1c. Then what else?
HIV testing, ma'am.
Yeah, that should be done. That should be done.
yes, ma'am. Mm,
HIV should be done. So a positivity or a negativity status. Even for enrolling in the drug no, in government scheme,
mm.
referring the patient to another government scheme, they ask the diabetic profile and the HIV profile of the patient before starting a ATT. So these you have to rule out. You need not go for a CT chest or MRI, but you have to
Okay, ma'am.
do the basic investigation. These are very basic that has to be done for this particular patient.
Okay.
Okay. What else?
Hepatitis B.
Hmm. Hepatitis?
Hepatitis B. We have to rule out.
HP. Okay.
HBCG.
Mm-hmm. You have to do an HPJC to rule out maybe. Why?
Uh,
You have to. Did you ask a drug history for this patient?
uh,
Especially drug history is very important.
yes, ma'am.
Like in this case, any history of what drugs can cause pleural effusion? Can you name some drugs causing pleural effusion?
Mm,
Somebody? Few drugs. I suppose everyone knows a mnemonic goes with drug causing pleural effusion. Anyone?
mm.
Hello?
Hello, ma'am.
Ah, any drugs causing pleural effusion?
Uh,
Amiodarone.
Amiodarone, methotrexate, Nitrofurantoin, so few drugs to be used can cause pleural effusion. And so, in this case, maybe because of tuberculosis, you are getting pleural effusion. And what are the risk factors of tuberculosis? Prolonged steroid drug intake,
Yes, ma'am.
high dose steroids
Mm.
when you prescribe for a rheumatological illness
Mm.
that time also, or patients with immunosuppressive disorders can have reactivation of this TB.
Yes, ma'am.
Then okay,
The
so
patient had
mm,
no significant treatment history, so uh,
okay, so speak drug history. You have to maybe he's been hospitalized or taking long drug, you can ask. Okay,
okay.
so you have done all this and you have taken the pleural fluid also out. So how will the pleural fluid be?
Uh, the pleural fluid would be exudative.
No, I'm just asking. No, like when you immediately when you see you take out how the color will be
Um,
Colorless
straw color maybe
straw.
uh, mm,
pale yellow straw color. Then
um,
okay, then you send the specimens for all these and you
yes,
get back the results.
yes, ma'am.
What do you expect?
Uh, TB.
No, what do you like? What? How
high,
will the reports be? Yeah.
high protein content
Hmm.
and low sugar.
Okay. There's a criteria.
Lights.
Price criteria is very
Yes,
important
ma'am.
to say. So simultaneously, what do you want to take?
To start
No,
anti.
no. To to make a lights criteria, you have to you get the pleural fluid, LDH, and the
LD.
serum LDH and protein at the same time.
Yes, ma'am.
Okay. So you have to take out the pleural fluid and the serum LDH and protein at the same time and go for the investigations. And what do you see? What is rights criteria? What do you see? Anything?
Uh,
Yes,
in
yes.
in transudate versus exudate, protein content would be pro-
More in exudate. So
Hmm. Yes, yes.
more than zero point 0.5 of serum protein.
Hmm.
And if it's less than zero point 0.5, it would be a transudate.
Okay.
Then LDH, if it's less than zero point 0.6, it's transudate, and more than zero point 0.6
It's exudate.
exudate.
Then one more is there, no? Lights criteria. LDH, pleural fluid LDH is more than two-thirds of the serum LDH. So if it's matching, then you say an exudated. So what type of effusion this TB will have?
uh, ex uh,
Exudated. Okay, very good.
exudate. Yes,
What?
ma'am.
Okay. Few causes for exudated pleural effusion other than TB.
Yes. What, ma'am?
Few causes of exudated pleural effusions other than TB.
Empyema.
Okay.
Hello.
Okay, ma.
Then
Want to say pus? Okay. Pneumonia. Any
yes, ma'am.
complicated pneumonic pneumonia with pus? Okay.
Mm,
What else, ma?
Pleuritis.
Flu?
Malignancy.
Okay, malignancy. Yes.
Then
Some of the lymphomas and leukemias can have. Pancreatitis can have this
yes,
sort
ma'am.
of uh, picture. So few
Trauma.
causes of uh, trauma when there is hemorrhagic
Yes, ma'am.
to the blood. Then transudative,
Mm,
few
Exudative.
causes for transudative.
Congestive cardiac
Cardiac
failure.
failure.
Yes, very good. So what is the most common difference between exudative and a transudative pleural effusion? How will the presentation? So transudative will be
Fluid overload symptoms.
fluid overload maybe. Yeah, it will be a bilateral. It's common.
Yes, ma'am.
They present you with a bilateral pleural effusion.
mm,
usually mild, not more,
mm,
mild to
mm.
moderate. Okay. This exudator will be localized either to the right or the left,
Left.
mostly. Very less likely to be bilateral. If transudative, also known as hydrothorax, will be a bilateral presentation. So, as she tell, congestive cardiac failure. What else? What are the causes for fluid overload? Maybe.
Chronic liver disease,
Hmm.
kidney disease,
Hmm. Renal liver disorders with hypoproteinemias.
malnutrition.
Patient with hypoproteinemia can be having a generalized edema also. They can present you with a anasarca. When you, if patient has fetal edema, when you take an X-ray, they can have a bilateral pleural effusion also. What else? Hmm.
Mm.
Then
Then
any thyroid disorders,
uh,
hypothyroidism
Hypothyroidism.
yes, ma'am.
can present you with
Mm.
such a feature. Then can you tell me some condition where mostly present with left-sided pleural effusion, as in your case? In your case, you want to localize this tuberculosis. Any predominant left-sided
Pericarditis.
pleural effusion? Yes, ma'am.
Mm.
Pericarditis.
Pericarditis will have a pericardial effusion.
Pancreatitis.
Yeah, pancreatitis can have pancreatitis. Then
Esophageal rupture. Esophageal.
it depends upon the level of rupture also. Mostly left side. Okay.
Yes, ma'am.
And what else?
Subdiaphragmatic abscess.
Ma'am?
Subdiaphragmatic abscess.
Okay. Can be only both,
Left
no?
side. Oh,
Left and right.
oh.
Left sided diaphragmatic abscess can be the left sided pleural effusion. Then you proceed to the slide. Ma'am.
Yes, ma'am. Treatment, therapeutic pleural tapping, thoracentesis, then anti-tubercular regimen. Hello, ma'am.
Yes. What are the
Shall I?
drugs given, ma? The ADT?
DT, rifampicin, isoniazid, uh,
Pyrazinamide ethambutol.
Mm. These are the first line drugs.
yes,
Second line?
second line,
Fluoroquinolones. And,
Mm.
injectable aminoglycosides.
Kanamycin.
Kanamycin, amikacin.
Okay. So you are giving treatment.
yes, ma'am.
ADT, you have started ADT. What else you will advise him?
Um, the side effects of an
Cough
ATT
drops.
drugs, hepatotoxicity,
Okay, you have to advise on the nutrition also.
yes, ma'am.
So ask him to take a high protein diet and proper
Yes, ma'am.
treatment. Okay.
Yes, ma'am.
Okay. Any doubts, ma? Put it in the chat box. No, I'll be there for 5 minutes.
Okay.
Any doubts? Okay.
Ma'am, these days people use methotrexate and nitrofurantoin and all, ma'am.